chairperson, panel members, and all my colleagues. Assalamu alaikum. Very good evening. Shobaike Bijoy Divosher Shubhecha. I'm Abdullah Shahriar from NICVD, going to present as you. I think it's a very debatable issue, at least the ground of DORV, which is still, we can define it. There is many school of thoughts. Now is my as a duty to present you. I think I will give some the school of thoughts. I'll give you all the expressions, and also some clips, so that you can go through this subject, that is TOF fallout and double outer right ventricle. So we all know that when to talk about TOF fallout, there is 4 issues. On VSD, we for the context of echo, we go for anterior melanine VSD, perimenous VSD without aortic tricuspid fibrous continuity due to a muscular rim, doubly committed subarterial VSD, AV septal defect in continuity to subaortic root, inlet type of VSD with straddling tricuspid valve. This happens in the case of VSD we found in TOF fallout, and others components you also know. There is alveolar obstructions. It's 2 type: dynamic due to some infundibular obstruction, and fixed valvular. And the complications then happens RV hypertrophy. In case of double out right ventricle, there is 50% rule overriding of the more than 50%. We know this kind of definitions all around. Overlap 50% or more of the other great artery over the right ventricle, there is a room of ambiguity. So difficult to determine when exactly the override becomes 50% or more. To overcome this issue, authors have used overlay more than 90% or more, distinct. And second school of thoughts is absence of fibrous continuity, this aortometal discontinuity. But it's not mandatory, because one can have fibrous continuity of mitral and similar anterior similar valve, with criteria of origin of great vessel being fulfilled. That is the great vessels theory, that there is more than 50%, but there is some fibrous continuity. So that's another dilemma. So some school of thoughts, they have given the idea that rather DORV is a disorder of ventricular arterial connection. So this is a plain echo where you have seen this overriding of the aorta near about 50%. So now the clip, I don't go for running clip, because for DORV it's better to define this thing. Here is also the overriding, and this is a thin arrow. This showing the as a I think displacement of the anterior mitral leaflet, then from the aortic valve. This is the aortometal discontinuity. This is this arrow is VSD lesions. So now we should know that before defining all these things, details of echo assessment of TOF and DORV. I'll giving you very short, because there's a time constraint. For detailed echo assessment, first you have to go for define the atrial situs and position of the heart of the thorax. Define the atrioventricular connection and the topology. That the loop is natural, there is always dual loop ventricle, whether it's D loop or L loop. Define the ventricular arterial connection. Define the pathological anatomy. Then VSD, site, size, numbers, aortic override and its degree, presence and absence of aortometal continuity. Pulmonary stenosis, the site, it may be valvular, subvalvular, supravalvular, or mixed, that is complex, and the severity. Then pulmonary arteries, the confluence, size, stenosis, aortic arch, aortopulmonary collaterals, and coronary artery anomalies. Some of the issues have also been addressed in case of double right ventricle, because In fact, tetralogy of Fallot is a part of it, the DORV. We'll see it later on. So measurements, we go for pulmonary annulus measurement, pulmonary trunk, right pulmonary artery at origin and hilum just before its branching, left pulmonary artery at origin and hilum just before branching. And the classification according to the location of VSD in relation to greater artery, it may be subaortic, subpulmonic, doubly committed, remote. Equipment of DORV is a then we go for ventricular septal defect, subpulmonary outflow tract, subaortic outflow tract, and arch and coronary arteries. So this is a clip of after tetralogy Fallot. We have go for parasternal long axis view, and there is a overriding. It is a RV, is a LV, is a aortic valve. So there is no overriding more than 50%. So it is a case of tetralogy Fallot. And there is a bidirectional shunt, and we have some is a mosaic scene. In fact, I think this mosaic is due to aortic regurgitation, and that is a occasional findings in tetralogy Fallot with dilated aortic root and aortic regurgitation. This subaortic is a subcostal view, sorry, 5-chamber view, and this is a subaortic VSD. Is a subcostal view with overriding showing. And this is view is short axis view, whereas the conal septum is deviated anteriorly, and this is giving the impression of RVOT obstruction. This is a clip where you have seen the dynamic is a fixed obstruction, a dynamic obstruction. This is a way of RVOT. This is subcostal view, long axis. Another is short axis view, gutter artery. There's a critical PS. Okay, I'm just skipping. This is a component of tetralogy Fallot showing both dynamic and also the fixed obstructions of having the cursor over the pulmonary valve. This is another pulmonary artery leveling. Is a pulmonary atresia with tetralogy Fallot. This is a MAPTA seen in the suprasternal view. This is another black view. This is a short axis view showing the RVOT. And so adjustment of the DORV is a more than 50% overriding and that aortometal discontinuity. And this is a view of conal septal. This is a parasternal long view, subcostal. Greater is in parallel position. And in this view, you have seen that the scarcely view the VSD. This is the this is a remotely associated VSD. In case of DORV, the 4 classifications have done. The first thing is subaortic. This is resembling like TOF-like position. Another one is subpulmonary VSD, toxic vein anomaly. There is the position of PS pulmonary stenosis. Another is remotely associated VSD, and remotely associated is sometimes in lead type. And another is doubly committed VSD. In doubly committed VSD, the subaortic locus along with there is a more anterior superior extension of the VSD, giving subpulmonary another lesion. Another clip of DORV. This is a subcostal view having gate vessels from the same right ventricle. This is a RVOT giving the gate vessels in parallel positions. On the right is aorta and left is pulmonary. So detailed equipment detail besides avoiding issue of the to define tetralogy and DORV, special relationship of kinetic structures with both 2D and color temporary is helpful. Tetralogy fellow and DORV have different management on the basis of distinct eco findings, because in DORV there are more than that subaortic locus, there are other locus of VSD, and that way the surgeons have to take the decisions. Thank you very much. ধন্যবাদ সবাইকে। বিজয় দিবস শুভেচ্ছা সবাইকে জানিয়ে শেষ করছি আমার বক্তব্য। ধন্যবাদ।